Welcome to the primer video on HIV drugs. In this video, Dr. Schufert is going to help you make sense of the different classes of antiretroviral drugs. Be sure to pay special attention to the mechanisms of action and the side effects associated with each class. We hope you enjoy the video.
Let's look at the warm-up for Micro 24. First question, what's the most common cause of DIC? So the mnemonic for DIC causes is stop making thrombi, and that stands for sepsis, trauma, obstetric complications, pancreatitis, malignancy, and transfusion. The most common heart murmur is mitral valve prolapse. The most common coronary artery involved in thrombosis is the LAD, the left anterior descending artery. The most common cause of death in lupus patients is renal failure from lupus nephropathy. And the most common congenital heart anomaly is VSD. Next, what are the clinical manifestations of Addison disease? So you have skin hyperpigmentation, hypotension, weakness, malaise, anorexia, and weight loss. And then what's the cause of Addison disease? Well, it's an autoimmune disease usually that attacks the adrenals, causes adrenal atrophy. Then you're going to have decreased aldosterone and decreased cortisol. Next, what is the classic clinical presentation of a branchial cleft cyst? Well, branchial cleft cyst is a neck mass that lies laterally, anywhere along the anterior border of the sternocleidomastoid. So it's not a midline mass, it's often the lateral part of the neck. And the important feature is that it does not move with swallowing. All right, that's it for the warm-up. Now let's get started with the lecture.
Hi, I'm Dr. Jennifer Schufert, and I want to welcome you to our lecture on HIV drugs. Before we start, I would strongly recommend that you watch the lecture on HIV if you haven't already done that, because in this video, we're going to be going to that dark, scary place of HIV therapy. But fear not. There are a lot of difficult to pronounce names that can be difficult to remember, but we're going to get through it together, I promise. So let's start out with HAART, H-A-A-R-T, or highly active antiretroviral therapy. So what exactly does that mean? Well, HAART is a combination of at least 3 different HIV medications that attack the HIV at different points in its replication and infection cycle. And this is in order to control the infection and avoid resistance simultaneously, which is a huge problem with HIV. So we usually combine 2 nucleoside reverse transcriptase inhibitors, or NRTIs, into an NRTI backbone, and then we add a medication from a different class to it. But it's not your job for step 1 to remember all of the combinations. What you do need to know is which drugs belong to which category, know their general mechanism, and then try to remember some of the side effects, especially the common ones or the life-threatening ones specific to some of these medicines. Now, when do you start antiretroviral therapy? Well, this recommendation is changing constantly, and I am being totally serious. Every year the recommendations change. Currently, national guidelines recommend that everyone with HIV, regardless of CD4 count, start HAART. They do emphasize the increased importance of rapid antiretroviral initiation in patients with lower CD4 count. So for test-taking purposes, remember that anyone with HIV infection should consider antiretroviral therapy, that it should definitely be initiated in anyone with a CD4 count of less than 350 or a diagnosis of AIDS. So if you have a question where someone is presenting with AIDS-defining illness, like pneumocystis pneumonia, or presenting with a very low CD4 count, that patient needs to be on antiretroviral therapy. So let's begin with the protease inhibitors. All protease inhibitors end in navir. So there's saquinavir, ritonavir, indinavir, nelfinavir, fosmanprindavir, lopinavir, tipranavir, atazanavir, and darunavir. So what is their mechanism? Well, the assembly of new HIV viruses depends on HIV-1 protease. What does protease do? Well, it takes polypeptides that were translated from the HIV mRNA, and it chops these polypeptides into individual functional proteins in order to allow new infectious virus to form. So the protease inhibitors prevent development of new viruses and halt that replicative process. So we need to talk about toxicity. Turn to your study guide now, and let's talk about some of these toxicities. GI intolerance, this is the most common one. It includes GI upset and diarrhea, and you can think of this as a class effect of the protease inhibitors. They also commonly interfere with cytochrome P450 system, and this can be a huge pain when you're starting other medicine on an HIV patient and you have to worry about a million drug-drug interactions. But we do try to exploit this effect of protease inhibitors, especially its strong effect in ritonavir, by using it to increase the concentration of other HIV meds. Hyperlipidemia and hyperglycemia. These sorts of metabolic abnormalities are another class effect of the protease inhibitors. Lipodystrophy. This is when fat gets redistributed in the body. There's fat atrophy in the face and in the distal extremities, while there's fat accumulation in the abdomen and at the base of the neck or the top of the back, the so-called buffalo hump. There's a debate about how much protease inhibitors contribute and how much is due to NRTIs or the HIV virus itself, but for now it's still considered a class effect of the protease inhibitors. Pancreatitis. Ritonavir can cause pancreatitis, but it's pretty uncommon. And nephrolithiasis, which is associated with indinavir and atazanavir. So if you have an HIV patient taking drugs for HIV and they get kidney stones, your answer should be indinavir or atazanavir. Also remember increased bilirubin with atazanavir. It can cause jaundice. Next, we're moving to the nucleoside reverse transcriptase inhibitors, or NRTIs. These are a little bit harder to pronounce sometimes. Zidovudine, didanosine, lamivudine, abacavir, and emtricitabine. And there's also one nucleotide reverse transcriptase inhibitor rather than a nucleoside reverse transcriptase inhibitor that's now part of most recommended regimens, and this one is called tenofovir. Now, how do these work? They basically inhibit the HIV reverse transcriptase enzyme. In order for HIV to replicate, remember, it has to be able to make double-stranded DNA from its 2 strands of RNA. And normally you transcribe DNA to RNA, but this is kind of reverse engineering of DNA from the RNA, so you use the enzyme reverse transcriptase. So if you have a reverse transcriptase inhibitor, you prevent the virus from being able to replicate. These NRTIs are all nucleoside analogs, either guanosine analogs or cytosine analogs. So when the HIV reverse transcriptase is churning along making DNA and it needs a guanosine, it grabs a molecule of zidovudine or didanosine instead, and the drug binds to the reverse transcriptase, binds right into the functional site of the enzyme, and it shuts it down. Now, what do we call a drug that acts at the enzyme's functional site? We call that a competitive inhibitor, right? So these NRTIs are all competitive inhibitors of reverse transcriptase. In a minute, we'll see that non-nucleoside reverse transcriptase inhibitors, or NRTIs, are non-competitive inhibitors. And then one other thing to remember about the NRTIs is that they have to be phosphorylated or activated by thymidine kinase in order to work. So you might want to make note of that. So for clinical use, let's start with zidovudine, which is also known as AZT. It's used in newborns who are born to HIV mothers to prevent HIV infection in those newborns. And it's also given as a single agent to pregnant women at the time of delivery if she didn't have antiretroviral therapy prior to delivery. But if a pregnant woman has been taking antiretroviral therapy during pregnancy, then she's supposed to just continue her usual antiretroviral therapy regimen. Now, for occupational exposures, a 3-drug regimen is now recommended. This is a brand new recommendation. And the post-exposure prophylaxis should be continued for 4 weeks. For over 10 years, a 2-drug regimen was recommended for occupational exposures, but this was just updated in 2013. And now we give a 3-drug regimen to everybody that's been exposed. Okay, let's talk toxicity. Again, I want you to look at your study guide here and fill in the table that covers NRTI toxicities as we go through these. First, most of these can cause some bone marrow suppression, but I want you to especially remember zidovudine. So if you see a question about anemia or leukopenia, think of zidovudine. It can also cause GI intolerance. For pancreatitis and peripheral neuropathy, think didanosine. There are a couple of older NRTIs that we don't really use very much anymore that can also cause neuropathy, and those are zalcitabine and stavudine. But for pancreatitis, especially remember didanosine. Didanosine and stavudine can also cause hepatic steatosis. So what's steatosis? That's fatty liver. So you get infiltration of fat into your liver, which can cause inflammation of the liver and elevated liver enzymes. Abacavir can cause a life-threatening hypersensitivity reaction, so I think this is another important one to remember because it's life-threatening. Next, we're going to move on to the non-nucleoside reverse transcriptase inhibitors, or the NNRTIs, and these include nevirapine, dolaverdine, efavirenz, etravirine, and rilpivirine. We mentioned that these non-competitively inhibit reverse transcriptase by binding to another site that's not the functional site of that enzyme, but it's still inhibiting the reverse transcriptase. And these do not require phosphorylation to be active. Remember how the NRTIs needed thymidine kinase? Well, these don't. So toxicity. This again is in your study guide. In NRTIs, these drugs can cause rashes, so remember that. The big side effect of efavirenz is neuropsychiatric symptoms like nightmares and vivid dreams, dizziness, and worsening of major depressive disorder, causing even suicide attempts. Efavirenz can also cause false positive tests for marijuana, so false positive tox screens. And another big one for efavirenz is that it's teratogenic. Okay, before we go even any further, I want you to pause the video for about 15 seconds and write down as many protease inhibitors as you can. Then write a list of all the NRTIs and a list of all the NNRTIs. And when you've done that, check your list and then restart the video and we'll continue. Next, let's talk about a drug called enfuvirtide, which is a fusion inhibitor. This goes back to the HIV lecture when we were talking about the envelope peptide and GP41. Enfuvirtide would bind to the viral GP41 subunit on the surface of the virus. We said that the GP41 subunit allowed the HIV to fuse to the host cell. So enfuvirtide inhibits the fusion of HIV to that host cell, which then blocks HIV from infecting new cells. This drug can only be given by injection and is very expensive. So we usually only use this in patients with a lot of drug resistance and then continued viral replication despite the best antiretroviral therapy that we have to offer. The primary toxicity that we see with this one is injection site reactions, especially these little tender subcutaneous nodules. It can also cause an increase in the risk of bacterial pneumonia. The next drug I want to cover is called raltegravir. Remember that we talked about how there is an enzyme called integrase that helps HIV DNA integrate into the host DNA. So raltegravir is an integrase inhibitor. Its side effects include nausea, rash, and myopathy. Another integrase inhibitor that's on the treatment guidelines is elvitegravir. And our last drug that we're going to talk about here is maraviroc, which is a CCR5 antagonist. Remember how we said that in order for HIV to infect a cell, in addition to the GP41 and GP120, which are on the virus, there's another cofactor on the host cells. There was one called CXCR4 and another called CCR5. We said that macrophages tended to have CCR5 receptors on their cell surfaces so that certain HIV viruses will use that CCR5 receptor on the macrophages to help that GP120 grab on to the host cell. Well, that's where maraviroc is active. Maraviroc binds the CCR5 receptor on these macrophages and CD4 T cells and inhibits that GP120 conformational change so that the virus can't grab onto that host cell effectively. Now, before a patient is given maraviroc, they have to undergo a tropism test to ensure that the patient is infected with an R5 virus and not an X4 virus. Some people will have all X4 virus and some will have all R5 virus, and then some will have a combination of both called dual tropism. Maraviroc can only be used in patients with all R5 virus. If the patient has any amount of X4 virus detected on the tropism test, then they don't qualify for treatment with maraviroc. All right, that's it for the HIV drugs. And now it's time for the end of session quiz. So I want you to pause the video, answer the end of session quiz questions, and then restart the video, and we're going to go through the answers together. All right, let's get going. First question, categorize the following agents as a protease inhibitor, NRTI, or NNRTI. So ritonavir is a protease inhibitor, didanosine is an NRTI, dolaverdine, NNRTI, zidovudine, also known as AZT, is NRTI, abacavir, NRTI, lamivudine, NRTI, nalfinavir is a protease inhibitor, and efavirenz is an NNRTI. Next question. What are the two HIV envelope proteins and the drugs that interfere with them? The first is glycoprotein 41, and enfuvirtide is the medication that will block that. And then the other envelope protein is GP120, and the drug that we're looking for here is maraviroc. Remember, maraviroc doesn't affect GP120 directly, but it binds to the CCR5 receptor on the macrophage, so the viral GP120 can't bind there, and the virus can't then enter the cell. Last one. Which antiretroviral or antiretroviral class matches the following statements? So side effect is lactic acidosis. And this is a class effect of the NRTIs. Side effect of GI intolerance. Remember protease inhibitors with this one. Side effect of pancreatitis. Remember, mainly there's two drugs that I want you to remember, didanosine and ritonavir. When you hear pancreatitis as a side effect of antiretroviral therapy, though I think that the most important one to remember is didanosine. Side effect of peripheral neuropathy, we said didanosine, and then the older drugs stavudine and zalcitabine. Side effect of megaloblastic anemia, zidovudine or AZT. Side effect of rash, remember that NNRTIs are your major culprits there. And side effect of hyperglycemia, diabetes mellitus, and lipid abnormalities, this is a class effect of the protease inhibitors. And the side effect of bone marrow suppression, I want you to think zidovudine again, given to pregnant women with HIV. Well, zidovudine is given to the HIV pregnant women who aren't on antiretroviral treatment during their pregnancy. Pregnant women who are already controlled on antiretroviral therapy just stay on that same treatment during labor and delivery. Regimen for occupational HIV exposure. A 3-drug regimen is recommended for everyone with occupational exposure to HIV. And a combination of different classes of medicine that are used to attack the HIV at different points in its replication or infection cycle in order to control the infection and avoid resistance. This is the definition of highly active antiretroviral therapy. And that is it for our end of session quiz, and that's it for our lecture on HIV drugs. I'll see you next time.